All right. Well, hello, everybody, and welcome to this week's episode of Perspective Matters, This Week in Behavioral Healthcare. My name is Glenn Hadley. I'm the Director of Operations for Southworth Associates, and I'll be your host today. Just really want to give any of our new viewers out there an idea of what we do here on the show. Our goal here is to address topics in behavioral healthcare, ranging from clinical, operational, marketing, business development, and even get into some public policy. And what we like to do is bring mentors, people that have been in this field for a while, that have kind of seen the ups and downs and where we're at, and put that in perspective, but also to connect mentors with people that are coming into the industry. And so that's kind of the goal, and that's what we like to do here. I'm really excited about our show today, and glad to have our guest, Dr. Leah Bennett, here today, Leah Claire Bennett. But first, before we get into that, I want to thank our sponsors for allowing us to put this thing on. So today our show is brought to you by RevWorks. They do billing, especially related into behavioral healthcare. And so if you guys have any billing questions, or you're looking for a company to come in and take that off your plate, you can call the team over there, Angelia and the team at RevWorks, and they'll take care of you. And the same thing with Dreamscape Marketing. Dreamscape has been in the behavioral healthcare field and really are leaders in our field when it comes to marketing. And so for any of your marketing needs, you can reach out to them. So definitely go to their websites, check them out, because without them, the show doesn't happen. So thanks to those guys. And all right, so now moving on, I want to introduce our guest today. So our guest on Perspective Matters is Dr. Leah Claire Bennett. And she's a licensed psychologist and serves as the Clinical Operations Director of Pine Grove Behavioral Health and Addiction Services. Dr. Bennett also oversees Pine Grove's professional treatment programs, including the Professional Enhancement Program, known as PEP, and Pine Grove's Professional Recovery Track, which is designed for the organization's addiction treatment patients who hold a professional license. She also earned her undergraduate degree in psychology from Baylor University in Waco, Texas. So she's a Baylor Bear, right?
And Bears, yes.
Yeah, come on. Right. So we'll get into that here in just a little bit. Being from Central Texas too, I kind of know how that works. And then she got her doctorate in counseling psychology from the University of Southern Mississippi in Hattiesburg. So Screaming Eagle too, right? So Bear and Screaming Eagle, come on. So that's good stuff. And Dr. Bennett's worked with the Professional Enhancement Program since 2005, where the focus is working with professionals with vocational and relational issues, maladaptive personality problems, addiction, disruptive workplace behavior, and sexual issues. So I'm really excited to have Dr. Leah Claire Bennett with us today. And so welcome. Thanks for being on the show.
Yeah, thank you. Glad to be here. Excellent.
Cool. So if you don't mind, talk to our audience, tell us a little bit about how did you get started in this deal? How did you go from being a Baylor Bear up in Waco, Texas, and doing all that there to getting into our field?
Well, I knew at an early age, I guess I wanted to go into the helping profession, and then went to USM. It is closer to my hometown, so moved this way to be a Golden Eagle. And then after completing my doctorate, needed to go on an internship. You have to apply, go through the match process. And so trying to avoid uprooting my family, Pine Grove is right here in Hattiesburg. And so I chose to come here. And from day one, I fell in love with this work, and I haven't left. So starting out as an intern 15 years ago this August, and sticking around. I've loved being able to see the change in people, working with professionals oftentimes, but also working in all the other programs and getting to see people's lives really turn around for the better, and is something that I've absolutely loved.
You know, it's fun talking to all of these different people that we come across in our field, and to a man and to a woman, when you start describing that moment, right? Whenever that person makes that fundamental change, and trying to find the onus for it, right? And what caused that, and how can we be a part of that? It's just an amazing deal. So yeah, I totally get that. And it's great to hear from so many people, because that is why a lot of us get into this field, right? Is to see that transformation. So Very cool. Like, who were some of the people that you looked up to whenever you got into this deal?
There was one, Dr. Alexis Polis. She's now the director at Florida PRN. She was the addictionologist psychiatrist here when I first started. And I have admired her throughout my career in terms of her ability to, she was just an astute diagnostician, and could really get to the heart of what was going on with a person. I think oftentimes people come here and they come here because of an addiction or because of this problem. And there's so much more going on that we have to be able to examine and look at for the picture or the whole picture. And she was just, she was a leader in being able to challenge the team to really conceptualize cases in a very dynamic and challenging way. So I've always, I still kind of have flashes of her in my head when I'm thinking them through cases and conceptualizing cases of questions that she would ask that really challenged the status quo. So I definitely think that Dr. Polis is one. The other one is, you've probably met Dr. Philip Hemphill.
Yes.
He was here and he's hilarious and was fun to work with his New Orleans accent. And fun that he always brought to the table. But I would say one of the major things that he taught me was being able to work with patients in a way that's supporting them, but also very challenging. So never going and being all one way or the other, but being able to find that balance to where you're honest with people. You shoot them straight. You don't beat around the bush. But you also can be very compassionate and caring and supportive. And that's a very hard balance to strike oftentimes. And it's something that, from day to day, you're not going to hit it right in the middle. And really watching him for many years be able to do that, I think I learned a great deal from him about that.
Absolutely. I've had the opportunity to actually play around to golf with Philip, and
He's
very much
hilarious.
the same way. Oh, so much fun. We had a blast. I don't even remember like how it went on the golf course or what like that, because we had such a good time, so
Can't forget him. He's an unforgettable person for sure.
absolutely. He's someone I'm definitely reaching out to have on the show, because I do respect his opinion a lot, and
Yeah.
his belief in outcomes too, and work in
Right.
that is phenomenal.
Yeah.
Yeah, he's a great guy. Let's see. So let me ask you this just real quick. What do you guys, I want to dig into the professionals bit just to go into that a little bit deeper, because, one of the things studying the history of our field of addiction treatment over the years, and seeing how, at the turn of the century, whenever we started getting in turn of the 20th century, there were so many programs out there, and people treated addiction, treated professionals with addiction problems. And then, in the 1910, 1915, in that area, it's the criminalization of treating substance use really just put all addiction treatment and everything off to the side. And we got sent to, the insane asylums and stuff like that. And so people hid it, right? And so now, like, as we've grown through that and gone through some changes, and it's still pretty difficult for professionals, right, to come into or to even admit that there's an issue, right?
Oh yeah, definitely. I think that, just having to, they've worked so hard, they've trained so hard, they've gone to school for forever. Their livelihoods depend on them being okay, for them to be able to support their families, support themselves. And so to take that step and to say, I need help, is extremely difficult, I think, for them. In working with professionals, some come mandated from like physician health programs or from the medical board or from the JLAP programs, but some do come independently and want to recognize that they have a problem and want to get help. But I think it is particularly hard because it's not something, you think of psychological help as something, that's confidential that you can do, take care of kind of independently of your work situation. But that's definitely not true for them. It intermingles so much, which complicates the picture for sure.
So something I've worked with a lot of professionals and then also like professional athletes,
Right.
and I don't think anybody gets to a really high level in whether it's sports or their careers without having a very strong work ethic, but also a pretty healthy sense of belief in oneself and being able to accomplish things. I know I was always told, if Glenn, if you want to achieve something, you work hard and you go make it happen.
Mhm.
And whenever it comes to substance use, it takes a long time to work through that with the professionals and get them to see that maybe this isn't something that they can attack on their own. So what are some techniques and ways that you approach that and walk through that with them, empowering them, but also getting them to see the need for help?
That can be challenging. I mean, the thing that I think professionals in particular really believe is that failure is because they weren't trying hard enough, and so they have to work harder and harder and harder, and so they do really do, or they struggle to be able to allow other people to help them. And you look at people, especially those that the professionals from the helping field, that there's a long journey that they have to take when they first get here, from being the professional that's helping to actually sitting in the chair and being the person that's being helped. So I mean, I talked about support, using a lot of support and helping them kind of walk through that journey and understand that there is pain and sadness sometimes that comes with that, to giving up that control. The one that's going to have to listen as opposed to be in control is difficult to help them to see that. So supporting them through that, challenging them too, that that for recovery to work, they can't stay in control and call their own shots. That sometimes challenging them on that, to see that other people have walked this process. A lot of the physician health programs, they have years of experience and can help them through this if they'll allow that. So I mean, it's not an overnight deal for them to be able to get there, and some move faster than others, but it is a journey when they first come into treatment.
Do you find too, like one of the advantages that I find is that once they've made that shift in perspective, that they really get after it, right? Like you see
Yes.
them really take to it.
Yes, and that's the professionals. Oftentimes, I mean, they're extremely smart people, and they're highly motivated to really get the change going. And once they can admit they have a problem and they see the problem, you can see exactly what you just said about them really taking off in treatment and not just trying to get the boxes checked off, but really start to make those changes that are going to lead to lasting changes in their recovery.
Right on. On that note, whenever you're working with a professional or even just any patient in general, what are some of the tools and techniques that you've developed over the years? Do you have some people have one certain method that they use that kind of defines them, or I've seen others that use like a combination of different modes or methods. Like what do you find useful?
And working with professionals, I talked a little bit about the journey about not being in control. Oftentimes there are lots of personality factors that come into play. And that is a huge piece of the recovery process here. Number one, starting off with a really good look at diagnostically what's going on. What are all the pieces of the puzzle that we need to be examining and looking at, and being able to hit those head on. I think that's a major part of it. I think that the relational piece, when looking at things like personality disorders or personality traits that are maladaptive, really being able to talk about those and help people understand the way that they come across to others. Oftentimes you hear, and this is in general populations too, you'll hear people say, well, I didn't intend to do that. That's not what I meant to say, or that's not what I meant to, that's what I meant in the relationship. And helping them understand it's not about what you meant or intended. It's about the way that you impacted or you came across to other people. And so in the work with professionals, they can always want to have the right answer, but it's helping them see that you're hurting your relationship with other people by constantly having the right answer and wanting to be in control and wanting to be right and have the last word. And so that relational piece becomes a huge focus. So the family work that we're doing, the trauma work that's led up to these relational patterns that they have. I often talk to people about, relationships, we will repeat them. As human beings, we tend to repeat the maladaptive patterns that we've always had until we become aware of those patterns. And so I think a lot of the treatment process that I try to help people see is you've got to become aware of what hasn't worked so that you can change and become who you want to be in the future. If you keep repeating what you've always known, nothing is going to change.
Yeah, I believe in that 100%. I think a lot of what our job is in this field is walking side by side with someone long enough and to where they can start to see how they're affecting others, right? How this stuff, what they're saying comes out and is taken, because solitary, like alone, they have a real hard time seeing it. I mean, Lord knows that I've had that experience where you don't know what you don't know, and the only perspective that we have is what we see. And so we get to walk with that person long enough and guide them through it, and then be there whenever maybe something goes off the rails a little bit. It allows them to see themselves and how they interact. So I absolutely love. So what? Let's see. So in the relational approach, like whenever you're talking to that, what are some of the breakthroughs that you've seen? Can you give like maybe some case studies or something that some of the stories that you remember from some of those experiences?
Good gosh, every day here is one of those. So I mean, there are examples of. I guess I'll kind of rewind and say that one of the first things that we use here quite a bit is 360 feedback. And so on their treatment plans each week, they rate themselves in their problem areas. Their peers rate them on those same things, and then the treatment team comes in and does those same ratings. And what we sit down and go over is not the focus isn't on how bad or how much progress you've made. The focus is on the discrepancy between how you see yourself and how others see you. Wow. So spend time going over their circles or triangles. So the peers give them circles and the staff give triangles. And we go over examples. So if it was entitlement or grandiosity or a need to please others, we would give either the staff or their peers would give them an example over the last 7 days of the way you did this behavior. Initially, when people start getting that feedback, it's extremely challenging. They want to fight it. They want to say, well, I mean, we just did this dance earlier today. I didn't do that. I don't know what you're talking about. So as they walk through treatment, they start to realize that feedback is something that's there to help them. That these are blind spots that they have, and without this, that it's really a kind thing to do for people to share things that you don't actually see about yourself. So that transformation of helping people learn that I want to know, I want to hear feedback, even though it's uncomfortable, even though I don't like really looking at these things about myself, that is a hugely beneficial piece, that is how I will get better. And so many fights over that. People that, say, you don't see it right, you've got it all wrong, that's not the way I intended it, I don't know what you're talking about, to really understanding the value of, okay, so this is what's wrong. This is why my relationships time after time continue to fail. This is why I end up getting a divorce every couple of years. It's because this is the way I engage in relationships. And the most powerful part of that is not the staff feedback, but it's the peer feedback. I think it's when they can start seeing, so I can see it when my peer does it, and now I'm starting to see when I do it. There's a really big shift that people are able to make in that.
Wow. So the feedback from the peers in the milieu really makes a big difference, right?
Huge difference. Huge. You know, they struggle at first because I don't want to hurt them. I don't want to do these things. But once they start to get that this is to help me and this is to help them, they really start to open up. And it ebbs and flows. You go through this us versus them. All you want to do is hurt me. And it takes some coaching to help get them to that place as the milieu changes over time.
Well, and I bet it gives the patients in the milieu an opportunity to work on like the people pleasing stuff, like those kinds of issues that they walk through. So it's really therapeutic for both sides of the equation, right?
Right. And in recovery, if you've got people around you that are just telling you the good things, that's not going to set you up for the most success. So trying to find and identify people who will be honest with you, and learning what that looks like and what that feels like. And so people who struggle with anger, for example, so if they're very aggressive, and they shut down feedback, helping them see, what's your recovery going to be like if you tell everybody to go to hell every time they give you a piece of feedback. Right. You're going to struggle and be all alone on an island in recovery. So helping them make those connections between recovery and the way that those interpersonal dynamics will continue to either help them if they can change them or hurt them.
So, and so the relationship and talking about how we're perceived, that's the initial surface level, but then like let's talk about the underlying issue of the trauma it's actually causing the response in the first place. So like what do you see in trauma's relationship to addiction and how it drives it?
Trauma I think it is, in terms of addiction, I think people with traumas, they will use anything to cope. It's a miserable, those traumas that have been a part of their life that continue to replay, to have flashbacks to, every time they're in a relationship with somebody that reminds them of that, how that becomes a stressor for them. And I think addiction becomes a way to cope, to self-medicate with those things. I think what you just said is very accurate about that the traumas do drive a lot of the relational impairment that comes with the struggles that people are having. Actually do a lecture looking at personality disorders as a defense mechanism. Because if you look at things like narcissism, people, they're not necessarily, number one, they don't believe that they're the greatest thing ever. People with real narcissism, they really feel horrible about themselves. And they use the narcissism in order to hide what they truly feel about themselves. And so that defense mechanism, if you don't deal with the trauma, then they continually need those maladaptive patterns to be able to cope in relationships. So we work really hard on, number one, helping them work through those traumas so that they don't need those blocks in order to feel safe in relationships. And that's a hard walk as well for patients to take, because as we start stripping these things away, you're taking away the ways that they've protected themselves throughout their lives. So when they don't have those anymore, life can feel pretty threatening at times.
So let me ask you this, and a lot of times the two, you've got the substance use disorder and the trauma and trauma related responses, they go hand in hand. How do you approach those? Do you what's your belief on, do we start with one and then get to the other, or do we start unpacking both together? What's your belief on how to address those? Do we need to address both?
I think both have to be addressed. You do get to, and it depends on your level of care here. A lot of my career, I've been working in higher levels of care. So looking at residential or partial, but most of the time people are living on site or living in community with us. So that gives you a little bit more, I think, freedom and flexibility to work with and kind of push some of the trauma work. I think that's much more difficult when you're looking at like an IOP level of care or an outpatient, because you you can't get the stress level so high that they can't cope with what's going on. And trauma work is going to definitely make things more difficult. So I think depending on the level of care is kind of how much of an attack you can put on the issue. So safety, I always think, is number one, and making sure a person is safe with what we're doing. So do they have the coping skills to be able to manage outside of the therapist's presence? And then depending on how far along they are with building those coping skills, relapse prevention skills, then you start integrating in with the trauma work.
So what do you think about like time frame? Like what range is good for someone, like, let's say someone that's watching the show today that wants to start really digging in, they're seeing the trauma responses are coming out. They're starting to see some consequences in their life, and they're in recovery from substance use disorder. Like how long could they expect to be doing that work, to work on the underlying trauma?
The trauma work can take a really long time, or, I mean, there are the techniques that EMDR, for example. I love EMDR. It's a process that really, I think, truncates the time because if you do traditional talk therapy for trauma, I think that can take a very long time. There's cognitive processing therapy that is, I think, is usually a 12-week session. EMDR, you can get several sessions in and make significant progress with the trauma. So the time frames can look very different. And then, sometimes you start the trauma work and you realize it's too overwhelming, and you've got to pull back. You've got to kind of reinforce some of the recovery pieces. You got to work on their support network to make sure that they've got enough people around them to help support them through this work. So it's kind of I don't think there's a specific trajectory. It's got to be very individualized for that person and where they are in their recovery, and then the support network that they have outside of it.
Yeah, I found so often that we can do a disservice in our field if we dig into that stuff and work with an individual, but we don't have the support afterwards set up, and we haven't worked with the families that, we work with them and get them to a place of openness and understanding about the trauma issues, and then we send them back without that support, and so right. I believe 100% that we do need to, when we're addressing trauma, not just address it with the patient, but also with the patient family and their support system afterwards.
And I think the shorter lengths of stay are making this more and more difficult, because as a field, we know that the trauma, without treating the trauma, we're not doing a service to the patient. But you don't want to set them up for failure either, like what you're saying. Like if they're not ready to do that work, and they don't have the support network, et cetera, to be able to do that, it becomes very complicated. And so, pausing things, or talking about doing it in outpatient, working with outpatient providers before they leave treatment to set that up, to talk about timing and all sorts of things to get that process to where the person can complete it, but doing it in a way that's safe.
Yeah, I see the programs that are doing really good work out there are the ones that spend a lot of time in the discharge planning process, like really getting that person set up, because, unfortunately, we are in a time and an era in substance use treatment where we're being dictated length of stay by people that maybe not have the best clinical interests in mind. And, we can get into the argument back and forth about, who started the length of stay issue, payer, provider, whatever. But, I really think that now, just presented with the situation that we have and the current climate that we have, that the discharge planning is so important.
Critical.
And to make a transition just a little bit, but it's along the same lines of length of stay guidelines and the payer-provider relationship. One of the reasons we're kind of in this mess is because, providers over the years maybe had taken advantage of some loose length of stay guidelines, and payers were paying a considerable amount for people to stay in treatment, maybe longer than they needed to. And then they were asking us, well, can you show us, your outcomes. Can you show us like why does this person need to be in treatment? And we were like, well,
They
okay,
just need to be.
yeah. I mean, it just works, right? Like, sure,
Right.
we have 100% success rate for everybody that's in treatment for our whole time, but we had a really tough time afterwards. So, making that transition into outcomes, right? Like, what are some of the outcome or the barriers that we have right now with like providing really good outcomes in our field, because the payers are asking for it, now the consumer, right, the families are asking for it, and I think that we're all trying to do good work around it and trying to show that. But what are some of the barriers for providing outcomes?
Well, I think, looking at people with addiction, they're not the most consistent individuals. And that, number one, is a very complicating factor. Just being able to track down people for outcomes is hard. I think, also when you look at something like breast cancer or some kind of blood disorder, like there are very concrete things that you're measuring and looking at. For addiction treatment, yes, you're looking at relapse, but there's so many other things related to the change process that are difficult to measure, that are difficult to kind of convey to payers, et cetera, to help them understand. So I think all those things definitely complicate the picture for us being able to do that outcome research. I think there are companies now that are definitely doing it, like the Omni Institute's doing a lot. We've used some of the Vista research group. They've put together a solid outcome survey where we're following patients for up to a year. But the reality is our outcomes, if you look at the data, most of it doesn't go past 12 months. So that's not a long time when you're looking at outcome, especially, relapse is part of addiction. And that's hard to conceptualize too. Is that a failure? Is that not a failure? So that becomes part of the difficulty. I think that the physician health programs and drug courts really have very strong abilities to help us with outcome and helping us understand outcome within addiction. Both of them with that 5-year outcome model is extremely helpful. And what they provide is that structure and accountability for people that allows them to have some longer term success. So I think that both of those programs that are being done across the country have shown a lot of success and have a lot of things that we in addiction treatment can learn from.
Absolutely. It's funny you mentioned Vista Research, because my guest next week is going to be Joanna Conti. She's coming.
There you go.
And we're going to chat a little bit about that. But one of our conversations that we have often is talking about recovery capital. And that concept is so exciting to me, because I do believe that we can't look at relapse as failure. It's
right.
just, it's not. It does happen. It's not like there's some people that come in and don't, that don't experience that, but there's a vast number that do. And we can't look at those as failures, especially if their quality of life is improved, if they've got new tools. I believe we're here to equip people with tools, right? And
right.
hold them long enough to maybe make some of those adjustments. But I totally agree. I'm excited about this idea of recovery capital and hope we can show some outcomes around that. What are some of the new things that maybe excite you? What are some of the new things that you're seeing that are exciting to you?
This is definitely one of them, of being able to create those outcomes and to show that. I think that ASAM is also doing a lot of work trying to help us as a field and developing, having more concrete things that we can refer to when we're treating these different patients that have different needs and what types of levels of care that they need. I think that all of that's very exciting, that we're moving from kind of this general, everybody needs 90 days to making it a very individualized approach and helping people or meeting people where they are to be able to get the help that they need. We've, over the last 5 years, I think we're a lot further than we were. in that. And I think that's very exciting for our profession.
Right on. So I just a couple more things, but I wanted to ask you, with everything that is going on in our current climate with the COVID-19 outbreak, what are you guys at Pine Grove doing? Like, how have y'all made that adjustment? Because it's like everybody was scrambling to really find out how we can still provide care, be safe in that care, because so many people out there are struggling right now, especially the healthcare workers that are treating these patients that are coming in one after another and going through their own trauma. So how have you guys adjusted to the COVID-19, and are there any things that you can share with others out there that maybe would help them in doing the same?
Yeah, I think, I mean, it's been a day by day, hour by hour at times, especially when this first kicked off, trying to provide the care that people need, but doing it in a way that's safe. And so, we had to implement, and I think most programs across the country is implementing, the temperature checks, the questions regarding safety and where people have been, and being very careful. We've started doing COVID tests on every patient that comes in, which has been helpful as well, to make sure that the milieu is as safe as possible. It's not 100% guarantee, but it at least helps us kind of rule out as best we can. The other thing that I think's been a major help for us is consulting with other programs. Talking with other people as they're walking through this as well, and making sure that as guidelines are being developed, like, are we on the right page? Because I don't think anybody knew what to do. No, there was no playbook for this.
Yeah.
And we really needed one. So we did consult with did a lot of webinars, just tuning in as much as we could, trying to find safe practices for people. So there's the telehealth option has also been something that, I mean, here we are on Zoom right now. I mean, I don't think I'd ever done a video conference with anyone prior to this world, but I mean, it's used every day, multiple times a day. Our outpatient providers use Zoom for anybody that wants to be seen via Zoom. We also, at one time, we were doing some IOP for people who couldn't come in. So just trying to broaden our, the ways that people could access us here at Pine Grove, so that they could get the help that they need, because people needed help. I mean, they still do. The isolation that people feel, the risk of relapse that they have around that, just people not being able to go to meetings and have that support. I've heard so many people talk about that. And being able to respond so that we can be a safe place that if we're needed, we can be open and available.
Yeah, I'd say that has been one of the unintended consequences that have been amazing out of this is now people have access to services. Whereas, before they did. I remember talking to Keith Fearman, and he was saying they built this beautiful virtual IOP thing because they wanted to give that added care for all of their remote patients, right? And now, because of this, everybody's gotten into it. Now people are using it. Now we even are being reimbursed for it as a service, and I'm really glad to see that happen.
Right. It's exciting, and there would be pieces that I would have said that'll never work. So when it became a necessity, you make it work, and I think there will always be limitations, just like there are other limitations to what we were doing before. But it's being able to be open-minded and to work with those, as opposed to just shutting down those options.
Absolutely. So last thing I want to ask you is that, one of the premises for this show is to provide mentorship for people that are either new in the field or getting into it. So like, what are some tips, or what would you say to someone that is looking to enter into our field of substance use addiction treatment, or even the behavioral healthcare world? Like, what advice would you give for them?
I would say patience is number one. Really understanding that there are lots of complexities to the disease of addiction. And there are there's a whole person that needs help. And stopping the substances is just part of the issue, and it's just step one. And there's so much more work that has to be done. Another thing is to really think about that when a person relapses, it's not personal. It's not that you didn't do a good job. It's not that you're a failure as a provider. That is part of that process, and really taking a stance with clients or patients that, what can we learn from this? I think challenging, I always want to look at myself and, look at how I'm approaching things, and then helping the patient do the same thing to where they can explore those pieces as well, so that they can learn from the experience. And then I guess, finding other mentors, like what you're saying, is critical. I think addiction is cunning, baffling, and powerful. And that's a very, very true statement. And to know that if you're going to help individuals with addiction, you can't think that you're smart enough on your own as an early clinician that you're going to be able to know how to handle all those situations. You need help. And so find people who have been doing it a long time and use them as resources. I would say would be the top 3 things that I would recommend.
That's awesome. I really appreciate that. And actually, on that note, what I'm going to do is I'm going to put your contact information up here in case there's anybody out there that would like to get in touch with you and kind of chat about this. So that's Dr. Leah Claire Bennett's information up there. And I really appreciate you sharing that, because I do believe that, all of the issues that we have in the field of behavioral health care, whatever side of that you're on, can be solved through good mentorship. Right. Because so many of our problems are repeat mistakes. Yes. It's already been made before. And so I really appreciate you sharing with that. Is there anything else you would like to share with the audience before we close today?
Just how much I've appreciated this. This has been a great opportunity, and I'm very happy to have been included to get to do this. Thank you.
I just can't thank you enough for being on the show and being a part of this, and definitely look forward to hopefully some people reach out to you. And
yeah, I'd love that.
Keep doing some good work here. So, all right, I'm going to go ahead, and I want to thank our sponsors again, RevWorks Billing. I put their website up there. Or once again, for any of your billing needs in the behavioral healthcare space, you can reach out to Angelina and the team over there. They'll get you taken care of. Also, for any of your marketing needs, you can reach out to Dreamscape Marketing. There's their website there. And also, if you'd like to chat with me, Glenn Hadley, the Director of Operations at Southworth Associates, please reach out to me. Just like Dr. Leah Claire was talking about the professionals and the monitoring afterwards, we do a lot of those programs, and I'd love to chat with you guys about that. Also, if you'd like to make the transition to a virtual platform, we've actually built a virtual conference platform to put out virtual educational events in our space, and so we can keep doing those and get the continuing education hours that we also desperately need. So if you're interested in any of those things, please reach out to me, and we'd love to talk with you. So my guest next week is going to be Joanna Conti from Vista Research Group, and we're excited to have her on the show. And Dr. LeClaire, just thank you again for being here, and we will talk to you guys soon. Thank y'all so much for being on the show.
Thank you. Have a good day.
All right, you too.